Hello, everyone, and welcome to today's expert webinar for the 2019 MQii Learning Collaborative, focused on optimization of the electronic health record, or EHR, for nutrition care. My name is Kelsey Jones, and I'm one of the leaders at Avalier for the MQii, and I'll be facilitating the conversation today. So a few housekeeping items before we get started. All of your lines have been muted upon entering the event space, so should you have any questions or run into any technical difficulties, please send us a chat via the chat function. You can do so by either clicking on the chat function, you may see it in the upper right-hand corner of your slides, or you can do so on the bottom center section of your slides. If you scroll over it, you may see a little chat pop up. You can click on that and then send us any questions or comments that you have for the speakers, or if you're running into technical difficulties, send us a chat and we will help you address those. Please note that the way that this event will take place is that all speakers will speak to their slides first, and then we will move on to the question and answer at the very end. So you're welcome to send us questions throughout the session, but we will not pose those to the speakers until after they have completed presenting their slides. So our first speaker today will be Dr. Cass Kite. Dr. Cassandra Kite is a clinical nutrition specialist for inpatient and ambulatory settings at the University of Wisconsin Hospitals and Clinics. In this role, she is responsible for assessment, planning, and implementation of clinical programs, education, and interventions to provide effective nutrition-focused, patient and family-centered care. She also serves as an Epic EMR department super user, among other responsibilities. She is currently co-chair of the American Society of Parenteral and Enteral Nutrition Clinical Informatics Committee, and earlier in her career, she was a project manager for Epic Systems. Dr. Kite received her PhD in nutrition from the University of California at Berkeley, and her MS in clinical nutrition and BS in nutrition from the University of Kentucky. Dr. Kite, can you hear us?
Can you hear me?
We can. You sound great. All right. I will turn the slides over to you.
All right. Thank you. And since I can't find the chat function, do I advance them or do you?
You can advance them. You have control of the slides right now.
So you think so? I can't advance it. So can you advance it?
Okay, no worries. Yep, we'll take the slides back and advance them for you.
Thank you. All right. Good afternoon. It's a pleasure to be talking to you this afternoon about capturing data for the MQii project. I will speak specifically to how to identify options for data to use to respond to the request for your electronic clinical quality measures. And lastly, I'll be talking about things to consider when you're deciding what field you will use to say you completed a particular step in the MQii process. Next slide, please. So I am at the University Hospital as part of UW Health. It is a large integrated health system of UW-Madison, and it serves more than 600,000 patients a year in the upper Midwest, and people come from around the area as well. And part of UW Health is University Hospital, and we were the only hospital to participate in our MQii project, and it's a 500-bed regional referral academic medical center with a level 1 trauma center, burn, and other programs that you can see there. Next slide, please. The objectives we'll go over today are to talk about structured data options to use to capture information in your nutrition care pathway. And I use the term nutrition care pathway to include nutrition screening and assessment, diagnosis after you've done a nutrition assessment, and then your interventions and care plan to treat that diagnosis. The options for structured documentation are multiple in an electronic health record, and it's up to you to decide which one would be best for your organization. And third, as something I learned as I was helping implement MQii in our institution, is that you do have to consider your end users and all other factors before deciding which data elements to use. And next slide. This slide should look familiar to all MQii participants. And I just reminding us what the electronic clinical quality measures are. So I've already talked about those first 4, and then the second 2 are related to after you implement your care plan, how are you monitoring the patient's progress with that care plan? And lastly, once the patient is nearing discharge from the setting where you're seeing them, how do you communicate the malnutrition diagnosis to the next setting? Next slide, please. The electronic health record is in probably over 95% of all healthcare organizations now. And a reminder that when we are using electronic health record data to complete a nutrition assessment, we are getting information entered by all nutrition clinicians who are other healthcare disciplines, and they are entering important information that we use to complete the assessment. While MQii is generated from inpatient settings, all the things that we're talking about as far as structured data and communication of diagnosis, I just wanted to remind folks to consider not only the patient in the hospital or the long-term healthcare setting, but also patients that will be seen in a clinic. Next slide. The MQii project team needs to know and understand their data structure so that they can optimally help the teams that will be charged with extracting the data to send to Avalier. And so a question to just know off at a very high level when you're talking about extracting data is that the data needs to be stored in a way that can be retrieved. So something like date of birth or height or weight or something like that, that can be easily pulled in a data pool. However, if you have information that is typed manually into a progress note, that is not structured data that can be pulled to send to Avalier. Next slide, please. We'll talk about the definition of structured data. So it is data that resides in a fixed field, and the response is stored in a database, which allows it to be pulled into reports and flow sheets and graphs, and then used for data analysis. The important thing about structured data is that it is unambiguous, it is specific, and it's defined, and usually within allowed parameters. Example of an allowed parameter for a height, say for an infant, you probably could not enter a height of 5'6" for somebody less than a year. And blood pressure fields often have allowed parameters. The way that you are entering this data into the electronic health record is through checkboxes or drop-down lists or buttons or calculator fields. So as an example of structured data, that would be diagnoses, and those are within a particular database. And people that enter a diagnosis, they have parameters. They have to select from those in the database, as well as procedures and medications. You can't just type a medication into the ordering field and expect it to match to something if it's called other. And the other example for other is the allergies is also a database, and you can't enter other because the allergy database is used to look for any potential drug or drug procedure components that there might be a severe allergic reaction. So if you allowed something like other, then it wouldn't be able to do that. Next slide, please. Our MQI project path began when I first saw the email go out to the Aspen list on the Aspen emails that they were looking for more hospitals. And my first question was, I wonder how complicated the data mapping would be, because I knew our information systems and nursing informatics team members that are assigned to our department had limited availability at that time. And then once I had a call with Angel and Kelsey, and we went through a lot of the data elements, and I felt reasonably comfortable that minimal build would be required, I then proposed to our department management to proceed with MQii implementation. Next slide, please. Now we'll get into the specific electronic clinical quality measures, the first one being nutrition screening. And this is usually the easiest for anyone that will be sending data, because now there are so many standardized and validated nutrition screening scores, tools that generate a score. And that score indicates whether the patient is at risk or not. So if you have, however you have your system configured, the data can be evident in flow sheet rows or the visit navigator for the admission navigator for the nurse or the nutrition navigator for the dietitian. And the benefit of having a structured data for the nutrition screen score is that it can trigger automatic notifications and consults and be used for patient lists. Next slide, please. The second electronic quality measure is for the nutrition assessment in response to the nutrition screen score. So if we think about all the data that goes into a nutrition assessment, includes medical and surgical and social history, includes procedures that the patients had or imaging results, obviously laboratory data, medications, and then specific things that the dietitian might be entering either in a structured or unstructured format, which is your food and nutrient intake. Anthrometrics will be structured, and your physical exam findings from NFPE, those can be structured preferably, and if not, then they would be in the documentation note. The benefit of using structured data for all of those elements is that you can then pull it into your charting templates where appropriate. Next slide, please. Thank you. So here's some examples of structured nutrition assessment data that we have in our charting template. We do capture each specific NFPE finding in a structured format. We have buttons built into our nutrition navigator, And then this is a collapsible system smart phrase that will bring in the results. Our nutrition orders can be found in a print group, our lab data. We have links to labs. This is one in particular that I built, includes most of all of the pertinent nutrition-related labs. Medications, again, there's different ways you can bring in the medications that the patient's receiving. And then this is an example of how we bring in the body composition data from the vital signs in the nurses' fields. We bring in the weight and the method and the height and the method. We have structured nutrition goals that we would use. And if we diagnose malnutrition, we bring in the diagnosis and the context and the criteria. And that's what those numbers refer to, the actual flow sheet rows. Next slide, please. So for MQii, when you're thinking about your nutrition assessment, you want to think about which structured data element is unique that says, yes, I did this assessment in response to the screening score. So if we diagnose malnutrition, that doesn't necessarily mean an assessment was performed, and I'll explain a little bit more of that later. So your options to say an assessment was completed is that you have a new button that you click, yes, I did a nutrition assessment. But if you do that, you have to think about the impact on the staff for clicking another button. You can say, well, if we almost always do MQii, that could be one, or you can use a structured data element. So we use the nutrition diagnosis. We captured that in a structured format. So that was what we used to say that, yes, we identified a nutrition diagnosis, which isn't specific to malnutrition. It's just, yes, that says we did an assessment. Next slide, please. The malnutrition diagnosis has clinical and billing implications. So the way that is documented is quite important, and it's good for all the people in your organization to agree on what malnutrition criteria and that you will be using for documentation of that diagnosis. And you can share that documentation of malnutrition into other people's notes, and it can be monitored in other healthcare settings if it's added to the problem list. Next slide, please. When it's usually the dietitian that is diagnosing malnutrition with the specific criteria that your organization is using. And if you need to communicate that to the medical providers, there are different possible workflows that are described here. And another way is you can also add malnutrition to the problem list if your organization allows non-provider clinicians to document diagnoses specific to their discipline. And if yours doesn't, you might want to think about starting that conversation, because it is a communication tool, and problem lists cannot be used for coding. The benefit of having it in the problem list is then that diagnosis can travel with a patient across the healthcare setting. Next slide, please. So the third clinical quality measure is the malnutrition diagnosis. So again, how in your organization will you say, yes, they have malnutrition? We had been entering malnutrition on the problem list for 4 years prior to implementation of MQii, which means patients come into the hospital with a diagnosis of malnutrition. Other people might have put it on there, so it really wasn't specific to that screen at risk, to that assessment to say that a diagnosis of malnutrition on the problem list was specific to those two events. So we are using a structured data entry of malnutrition diagnosis by the dietitian, which is separate from the ENCP diagnosis because, again, they may be different, they may be the same. Next slide, please. This is an example of a smart phrase that we created. I showed you the sort of the flow sheet rows. So it says that the context and the criteria, and we've also added within our smart phrase that we discussed the diagnosis with the patient and whether they were able to participate in development of the nutrition care plan. Next slide, please. The fourth clinical quality measure is whether a care plan is developed. We decided to determine specifically that a nutrition care plan was developed if we entered some structured interventions. And again, we built these into our nutrition navigator. So this was one element of new build that we did. The dietitians at University Hospital and UW Health, we can enter diet orders and oral nutrition supplements on all the patients. The physicians can delegate enteral nutrition, so then we would either say we enter the orders or we recommend enteral nutrition. The same with parenteral nutrition, medications that we recommend, vitamin and mineral supplements, education and coordination of nutrition care, such as discussing the plan with the PCP, referring the patient to another dietitian. So these are all follow the ENCP interventions. Next slide, please. So the challenge to the use of these was that I thought, oh, if we build it, they'll come and they'll use it, but maybe not, because most all of our dietitians had smart phrases already formatted with interventions for their patient specific population. To go into the nutrition navigator and click the button was an extra step, and it wasn't buying them anything because they already had these things built into their smart phrases. So I do not see this as something being used in the future, but the compromise was that the dietitians would select the interventions in the navigator for patients just diagnosed with malnutrition and just during our MQii implementation period. Next slide, please. This is an example of the MQii data template that your representative sends to you. And I just wanted to show what we did at our hospital. So we used a data analyst team that could send the data. So those, if I have letters in there for Kurds, that means they go figure it out. But then I entered telling Kurds like where exactly to go find that a screening was done, where exactly to interpret what the risk means, what the number means, where to get the nutrition diagnoses, and so on. So you can, that was my part in doing this, working with the data analyst assigned to our project. Next slide, please. The last couple, and I'll just be quick, I'm running over time, the last couple steps in the MQii malnutrition continuing is reassessment. And again, you can use structured data that's in the electronic medical record. And again, we want to make sure that malnutrition can be monitored into the next setting. Next slide, please. And lastly, once the patient is being discharged and they have malnutrition, we need to think about getting information about that diagnosis and treatment plan to the next setting. And so there are some things to consider, as well as using the electronic messaging system within your electronic health record to send in basket messages. And if they are not part of the UW Health system, then our note can be faxed to them. Next slide, please. So in conclusion, I felt it was not, never too early to start your data mapping, because that starts the conversation about how much work needs to be done by other people to help you implement MQii. And the important thing for the folks listening today is that you're the nutrition expert, and you're the one that is who translates the required data elements in the way that you capture nutrition care in your electronic health record. If you understand data elements needed, that will also help facilitate completion of the IRB application, because you need to indicate all data elements that would be sent. And lastly, the creation of new data fields will impact other people. So you need to think about whether they wish to do this. Often I learned better ideas when I took things to staff members. So it's really important to engage the whole team in the conversation, because MQii implementation and data collection is a team effort. Thank you.
Fabulous. Thank you so much, Dr. Kite, for walking us through that. And I think kind of showing how the different pieces work in terms of where you collect the data, how you get, structured data, and how that supports your collection of those malnutrition ECQMs, as well as some of that intervention and discharge planning piece, which are a little bit beyond the ECQMs, but really critical to making sure that there is continued care for a patient who is malnourished or at risk of malnutrition, is really, insightful and helpful. So appreciate that, and hope some individuals can take that and bring it to their team. We'll now have Kurt Calder from Intermountain Healthcare share some kind of real-world experience implementing some of this at his facility. Kurt is a clinical informatics analyst at Intermountain Healthcare, where he supports all caregivers at one of Intermountain's 23 hospitals in their use of the electronic health record. He has worked in 6 hospitals in Utah and Oregon, spending the last 21 years at Intermountain and the past 18 years on informatics. His experience includes 10 years providing direct patient care across acute, outpatient, and community settings, including 3 years as a clinical nutrition manager. He works closely with the Intermountain team on nutrition-specific content in the EHR and supported the NCP terminology and coding work with the Academy of Nutrition and Dietetics between 2008 and 2014. Kurt is also the Utah Academy of Nutrition and Dietetics Executive Director. He received his BS in Medical Dietetics from Brigham Young University and his MBA in Information Systems from Weber State University. So Kurt, I will hand it over to you to walk us through your experience with Intermountain and how to apply this to the system that you all are using.
Okay, great. Thanks, Kelsey. I appreciate that. And can you all hear me okay?
Yep, you sound great.
Okay. I appreciate the opportunity to visit with everybody today, and I hope to share some of our experience with our EHR, especially Intermountain's journey in implementing the EHR, and specifically the nutrition part of that EHR. The things that are shown on this slide are the items that I'll talk about during the presentation. And I think I can advance the slides. Let me give that a try. Go backwards. Okay. I do work for Intermountain Healthcare, which is an integrated health system. That means that Intermountain owns all of their hospitals, the clinics, urgent care facilities, hospice, home care, their own insurance arm, and then also employs quite a number of providers. And one of the things that is great, we all love our mission statement. It's helping people live the healthiest lives possible, because it's simple, it's engaging, and it also reminds all of us what we're doing. In order to share where we are today, I need to step back and show some of our history. This slide shows our legacy system, which was basically introduced in about 1967. And when we retired it in 2017, it was 50 years old exactly. So it lasted quite a long time as one of the first EHRs. And it doesn't look real pretty, but it was very fast. People loved using the EHR, and our downtime was less than 1%. So you can imagine, a lot of you with EHRs who go down, every so often, it seemed like we never went down with the system, and so everybody did love that part of it. I also spent, in my first 10 years, a lot of time in paper records, and as dietitians, we used these records, and you can tell by this picture that they were quite busy and hard to read sometimes. And so in about the year 2000, I went to our IT department and asked if there was maybe some better way that we could record our information electronically. And as a matter of fact, they were looking for a project at that time. And so fortunately, they teamed me up with one of their developers. And together, I, with help from our dietitians, and then with a developer coding everything, we created this EMR. And it was specifically a nutrition EMR. We call it NuCard. That stands for Nutrition Cardex. And we were able to create a lot of different things within this because we had, control over all of the coding and everything with this system. It was integrated with our data repository, which information all comes from our EHR. And so the dietitian was able to go in and look at all of the labs and meds and histories and everything that would be needed for them to create their assessment on the patient, and then go in and document information on their patient. And so it was very usable, and I think that with all the changes that we were able to make over time, all of the dietitians really appreciated using it. We designed a special note template that pulled together all of the pertinent EHR data and information charted by the dietitian. And then a copy of the note was saved in NuCard, and then another copy was uploaded to the EHR. Between 2003 and 2007, as the nutrition care process terminology took shape, we embedded that data into our system. And you can see here we used smart searches to pull up the different problems that were there, which helped the dietitians find what they needed. And then when a problem was chosen, we used the Academy's etiology matrix to basically present those etiologies that were appropriate to that specific diagnosis. But they could also enter a free text etiology if they needed to. And then, of course, the signs and symptoms were also put in with free text. So it was integrated with our data repository, which really helped with the data. We implemented in 2001 and eventually put the system in all 22 of our hospitals and also all of our ambulatory areas. It had two main functions to the system. There was a clinical function and a productivity function. And as we went to our new EHR in 2017, that basically replaced the clinical function, but the productivity piece is still there since we didn't have anything to replace that piece. So in early 2013, Intermountain's EHR could not keep up with the rapidly changing landscape for healthcare technology and all of the legislation. So they started a search for a vendor, and not just to be a client, but to be a partner with that vendor. And then in late 2013, they announced our partnership with Cerner, and the Millennium product that we would create would be called iCentra, and you can kind of see how that name comes about here. iCentra was implemented in all Intermountain hospitals, clinics, and entities from 2015 to 2017, so it was kind of a big bang approach to that. So let's turn to the nutrition care process. This is the NCP model that we use today, that we're all familiar with. And early versions of the model were tried starting as early as the 1970s, but then the Academy adopted the model in 2003 and updated to the current model that we just showed in 2015. The terminology associated with the NCP began to surface in about 2003 and continues to evolve today. This next slide, I think pretty much every dietitian can probably recite all four components of the NCP. It's pretty much become the structure of our practice. So in the assessment piece, a lot of times the assessment is based on a dietitian's training experience and also practice guidelines and protocols. And it's a review of all of the data that's available, histories, meds, labs, vitals, etc. And then, of course, nutrition-focused physical exam. The diagnosis piece, this is something that the Academy embedded or helped us to put together. So the syntax is basically a problem related to an etiology as evidenced by signs and symptoms. And Cass talked a lot about structured data. In terms of the diagnosis, the problem usually is structured because that should be coming from the NCP terminology. And the etiology can be from the matrix, so that could be structured or unstructured. And then finally, the signs and symptoms are usually unstructured, usually free text, although some people do like to put those in a list and create structured data from those. There are a lot of benefits of using an EHR, and some of those are shown here. For us, one of the benefits was being able to chart right next to all of the other disciplines within the same system, so that definitely was a benefit. We also have decision support efficiencies. So we have things like alerts and rules, specialized rules, and decision pathways that kind of help us through the care of the patient. A lot of people use templated quick notes. Those are very useful. And also, sometimes if you have the ability to customize or enhance, that's always nice. Right now, we're trying to work on an enhancement that will help manage our nutrition support. And then the last benefit, and probably the most important, of course, is outcomes tracking. So if we can capture the information that has been charted and what has gone on with the care of that patient, it can help us to improve our care, improve our processes, etc. Some of the barriers with an EHR. I know that as somebody is early on with a vendor looking at their EHR, it might have more of a physician or nursing focus rather than, being very nutrition focused. Sometimes you wonder, is all of the nutrition assessment data available to the dietitian, or is it really hard to find? Some EHRs use flow sheets, some use forms, some use both, and there's definitely advantages and disadvantages of each of those. And then there's the question whether you can customize or enhance the system. Some vendors and in their relationship with the client allow that, and some are a little bit tighter. And then how does the system handle nutrition support orders and management of those orders, etc. So let's go to this next slide here. Oops, sorry, going the wrong way. I'm not sure how everybody feels about their own EHR, but I imagine many of us can find the good, the bad, and the ugly in our system. So I'll talk about some of these in our own system. So the good, and some of these are definitely wins for us. We do have all of our dietitians playing in the same sandbox with the other disciplines. We've also been able to integrate the NCP terminology into the EHR, which is really a nice thing to have, like we did in NewCard. We have also a documentation template that pulls in the appropriate charted data. And I won't say that all of these things started out in the very beginning when we first implemented the EHR, but over time we've been able to add a lot of these. We also, just recently in the last year, were able to make it so that the nutrition problem automatically populates to the patient problem list. So the dietitian doesn't have to go in and chart that separately. It just flows straight from when they do their PES statement. We have configurable workflow pages and views that walk the dietitian through their work. And Cerner feels like this is really important. So they're very strong on workflows for all different disciplines. The results and most of the data is usually quickly available. And then we do have a special team at Intermountain of developers that work with Cerner to create specialized functionality. And of course, it's not a huge team, so they're extremely busy. And because Cerner does allow us to do some of that enhancement, these guys are busy working on a lot of different projects. They're the ones that are helping us with the nutrition support management tool. And the hope eventually is to be able to pull a calculation of the nutrients from what has been given to the patient based on the order, and that the nurse documents according to that order, and then finally what the patient received, from the nutrition support. Also, part of the good includes our diagnosis. So again, we were able to embed the NCPT in the system so that we have drop-downs, and the dietitians can go to those drop-downs and find the diagnosis. And then the corresponding, again, etiologies will appear, and they can choose from those or just choose other and put something in there, and then the signs and symptoms that are put in by free text. And we've done basically the same thing with our interventions with drop-down lists and have all the information available. Unfortunately, this is the 2017 version of the NCPT, and that probably brings us to one of the bad issues. Sometimes it's hard to keep that updated. One of the things that was very glaring when we first implemented our system was that it was a huge step back for our dietitians when we first started out. And so they were not really happy going from New Card to iCentra. Over time, I think that we have added quite a number of things back into the system to make it better for them. We also have a lot of system slows because it's a very complex platform, and that's pretty typical of a large EHR. The same with most clients. Even though we have a partnership with Cerner, we can't always turn the ship, or we can't always make big decisions to make large changes. And so there's definitely times that we wait, or sometimes we can't even make decisions that they want to do. There are a lot of changes to the system based on Cerner's global strategies and changing technology. And then, of course, our nutrition outcomes are not tied to interventions and goals in our system. That's definitely a nice to have. Maybe someday we'll get there. And then finally, the ugly. I think that most of us would agree, despite years of efforts, both through legislation and healthcare efforts, we do not really have true interoperability yet. So a patient that might have come from, say, Ohio, and is in Tennessee, the doctors in Tennessee probably won't be able to pull up their record and see the information that's pertinent to that individual. And, we all hope for that, and hopefully someday that will come. And then something related to that, the nutrition data is definitely not coded in most of our EHRs, and I think that's a common misconception. So when I had the opportunity to work with the Academy, it was about 6 years I spent coding the NCP terminology into SNOMED and LOINC. And they still are working. There's a tremendous amount of work going on today with coding and getting the information into those terminologies. But just like the disconnect with interoperability, just coding our terminology doesn't mean that it automatically appears in our EHR that way. And I think sometimes people don't realize that and think that, okay, we put it in SNOMED, then it must be there and available for us with SNOMED codes. That piece, getting those codes embedded into the system, is another monumental task and will take quite a bit of work. And I've been able to spend time with the Academy and with with Cerner to emphasize the importance of having those codes on the back end and getting that into our system. And so this kind of really gives us an opportunity, really all of us who have EHRs, to collaborate in a lot of different ways. All of us are EHR clients, and we can work with our vendors and also with the Academy. I think that the vendors don't know really what's needed in the system, and the Academy would love to help and get that coded data into the vendor systems, but they're not always sure how to do that as well, because each vended system is different, and sometimes each client build is also different. As I've met with the Academy and with our vendor, we also came across a company in Chicago, Intelligent Medical Objects, or IMO. They are basically a translator of coded terminology in almost every EHR in the country. They're the main translator for Epic systems and Cerner, and then most of the other systems as well. So we did have some meetings with IMO. I think that work they're still having discussions between the Academy and IMO, and there's definitely some promise there, but they haven't yet built a good business case for IMO to take that on. But I do think that all of us have the opportunity to try to work with our vendor where we can. I know with Cerner, just this last year, there was a Cerner Nutrition Council that was formed. And if you are a Cerner client, it would be great if you joined that council, and that we all, all of us together put our voice in and work to try to get this information where it needs to be, so that as the Academy makes those updates every year, that it flows into the system rather than spending hours and hours putting those things in, by ourselves. So lots of opportunity, and hopefully we can all work on that together. And that's everything I have.
Fabulous. Thank you so much, Kurt, for that insight and kind of the background on both how you got to where you are today, as well as the real-world implementation of this, specifically in a Cerner system. And I know many of the participants on the phone today either operate on Cerner or Epic systems. So if you all have questions kind of related to just generally integrating them into your EHR or either of those specific systems, please feel free to pose them to Kurt and Dr. Kite. Just as a quick reminder, we always get questions about this. We will be sending the slides, the recording of today's webinar, and information about the CPEU credit shortly after the webinar. You should get it in the next day or two, so please be aware that those will be coming via email. And then you can also find that information up online on the MQii website. So please be on the lookout for that material coming to you. And that way you can revisit the slides or the webinar recording as you'd like, as well as ensure you get that credit. We're now going to open it up for question and answer. As a reminder, all of your lines have been muted, so should you have any questions, please send them via the chat function, which you should be able to find either in the upper right-hand corner of your screen, or if you scroll over the bottom of your screen, you'll see a little chat bubble. Click on that, and you can send us any questions or comments. If you have any issues, please let us know. But all of your lines are muted, so please send us questions via those functions, and we'll be sure to pose them to the speakers. The first question we received is for Kurt, and the question is, Kurt, what is your process for updating nutrition diagnoses and associated terminology in the EHR when new updates are released?
That's a great question. It's manual. And I think the last time that we updated, we've only updated it twice. I probably spent about 100 work hours updating that manually through spreadsheets and so forth. So it's a big process, and that's why I hope someday we can make that more of an automatic process. But yeah, it was totally manual, just basically plugging all of those in with our build person.
Okay, great. Another question is, how do I get on the Cerner Council? Do you have any suggestions on how to get on a specific council? I think that's, Cass, if you want to provide some thoughts on that from the Epic perspective too. But how do you get involved with your system's council for the EHR?
For Cerner, I would be happy if you want to email me, and I can connect anybody with that council. So my email is kurt.calder@imail.org. And again, I would be very happy to connect anybody up with the gal that runs that council, so feel free to connect with me.
Great, thank you, Kurt. And if anybody missed that email address, just send a question to the MQii email inbox, and we'll be happy to connect you with Kurt if you'd like to follow up on that. Okay, Cass, a question for you. What do you recommend to do about standardizing the use of smart phrases across your different RDs, particularly across different sites, to ensure parallel entry of data?
Smart phrases are a tool to bring in text that you often say, as well as data to particular data elements. In my role as a clinical nutrition specialist, I am the one that updates all of our templates to try to make sure there's consistency with the groups are the inpatient adult at University Hospital and our American Center Community Hospital. And then another group is pediatric dietitians. They're inpatient and ambulatory, but they have different sets of templates. And then our ambulatory dietitians just associated with University Hospital and TAC. So, you know, if we make one change in, if by department the managers say, well, we'd like to do this, then, you know, I put them in all the standardized templates. Now, everyone is free to make their own templates based off our standard assessment templates for the different specialties. However, if we make a change, so for example, in the last year, the manager said, you know, there is a nutrition diagnosis within the past year. It might still be relevant at this visit or this admission. So now we bring in a previous diagnosis from at least 1 year ago. And again, so that went in all the templates. And then if somebody has their own, then it's their responsibility to update it. And if I, in my role as a CNS and I'm doing chart review and I see that it's not updated, then I contact them directly. So I hope that answers your question.
Great, thank you. Another question, you know, I know both of you are on Epic and Cerner respectively, but a question has been around any recommendations or broad kind of suggestions that you might have about uploading the NCPT or malnutrition diagnosis into other EHRs. This question comes from somebody who is working on a build in point-click care and trying to get that into their system. So do you have any broad recommendations for working with other EHRs or maybe learnings from your own experience that might apply to other EHRs as people are trying to get those components into their systems?
I'm going to defer to Kurt because we use eMCP and we capture many parts of it in a structured data format. We have not employed any other links to SNOMED or anything else to do that. So I'll defer to Kurt.
Yeah, it is a little complicated. As I was saying earlier, each EHR and each client's build is a little bit different. So we roughly, again, we took the NCP terminology and through a matter of spreadsheets and so forth, we were able to use that information with our build person and enter it into the system. But I think in general, it's good to find out who does do the build for whatever system you might be using, and then work toward having them build that into the system as structured data, as drop-down lists or whatever it might be. And then the SNOMED side of it is really tricky as well because it's ever evolving. Right now, the Academy has been really working to make sure that the way that it appears in SNOMED is correct in terms of terminology. It's kind of a science of its own. And so I know that some of the things that we put in even back in, say, 2011, 12, have been changed somewhat in SNOMED today. And I think it's better what has been done today. So, but there is a lot of work that needs to be done, and those who are on a what do you call them, a data modeling team in your organization can help with that SNOMED piece of it if you have access to those individuals. So I hope that helps a little bit.
Great, thank you. Another question, we got a couple of questions related to how to connect some of the information that you're recording in your inpatient EHR to the next setting of care, and kind of both communicating it to the next in-line provider, especially if the patient is moving, to long-term care or post-acute care, and ensuring that data translates with them and moves with them as they go to the next setting of care. I know you touched upon this a little bit, Dr. Kite, but wondering if you have any other suggestions that could help those who are either working in an integrated system or not working in an integrated system kind of better communicate what's in the EHR to the next in-line provider.
Yeah, that's a great question. So for those in an integrated health system, if you put something into a flow sheet row or form or some structured data format, you should be able to bring that out in some sort of report. So in Epic's chart review, there's the flow sheet review functionality so that you can view data that's been put in by anybody else. And that's been a big help once we had flow sheet reports created for NFPE and malnutrition. Those two in particular have been helpful so that because patients with malnutrition are often in and out of the hospital, so you can easily see when was NFPE last done, when was malnutrition last diagnosed, instead of going through all the particular chart notes. As far as systems that are not integrated, I'm aware there are some HL7 forms that are possible, and maybe Kurt can speak to this more for discharge information. Otherwise, we are, dependent on getting that information into some sort of report that then would be sent to the next setting.
Right. So HL7 does have the standard for transmitting on discharge, transmitting that information to the next level of care. And right now, a lot of systems are compliant with that standard, but not everyone is yet. And so I think there's kind of a mix across the country.
Excellent. Well, thank you both for that input. We are now at the top of the hour. Really appreciate your time today and the insights that you provided, as well as the guidance. I hope this is helpful for those who were able to join and who are either kind of in the process of trying to capture data and better collect malnutrition data from their EHR, or maybe are kind of contemplating that, moving in that direction, but haven't quite gotten there yet. If you have any follow-up questions for our speakers, feel free to email us at malnutritionquality@avalier.com, and we'll be sure to try to pass those along to our speakers and see if we can get answers for you. Other than that, please be on the lookout for the webinar recording and the CPEU information following today's call. And thank you again for joining us and for your time. Have a nice afternoon.